Hello everyone, I am Anish Shah, and in this video I will be discussing with you about renal calculi. It is also known as nephrolithiasis. Nephrolithiasis. That means there is presence of a kidney in the renal tract, and that is known as renal calculi. And how does it happen? It is due to precipitation of the urinary solute as a stone. So basically, what happens is that this is our kidney, and every time our kidney is preparing a lot of urine via the filtration from the blood. So during the time of filtration, a lot of solutes gets filtered through the tubules, and eventually they will be taken into this area. This is known as renal pelvis, and from the renal pelvis, it will be carried into the ureter, and from the ureter, it is carried up to the bladder, and from the bladder, it is excreted via the urethra to the external world. So as we can see, there is a lot of solutes that so we can see a lot of solutes that is being filtered in our day-to-day life, and due to the precipitation of these solutes, it will be precipitating as a urinary solute, as a urinary stone. Uh, so this is how a renal stone develops, and renal stone can develop anywhere along the renal tract. And as we can see, it can develop anywhere along the renal tract. As I said, it can develop in the kidney, it can develop in the ureter, it can develop in the bladder, and it can even develop in the urethra. So, nephrolithiasis means development of the renal stone. It is due to precipitation of the urinary solutes in the form of a stone, and it can develop anywhere along the path of the renal tract. And we can see here, so renal stone, also known as urolithiasis. So it is a calculus formation at any level into the urinary collecting system. But it's a matter of fact to know that the most common site of renal stone is the kidney itself. The most common site being the kidney itself, and the symptomatic urolithiasis is more common in case of male as compared to female. So whenever both male and female can have urinary stone, and they can be unilateral as well as bilateral, but most cases are unilateral, and in most cases the male are very commonly affected, and male, when they are affected, they are most likely to have symptomatic urolithiasis associated with certain clinical features that I'll be discussing at the end of this video, and as compared to female. So this is all about renal stone, the introduction. And now we will look up to the fact how a renal stone forms. So as I've already said, every time in our kidney, there is filtration of solutes, and these solutes are being filtered in a day-to-day basis, and because of this filter solute, it is always a risk factor to have a kidney stone. And basically, whenever we are talking about kidney stone, it is more common in age from 20 to 30 years of age. So urinary stone develops when there is high concentration of solutes. So when there is high concentration of solutes, and the amount of solvent to dissolve these solutes is very low. So solvent is less, and when the solute is high and the solvent is less, in this condition, what happens that there is increased chance of precipitation. So there is increased chance of precipitation, and this will manifest with renal stone along the end. That can happen on the entire renal tract, and it is more common in the kidneys, as I've already discussed. So what are the factors that causes precipitation? And there must be certain factor that will try to prevent the precipitation of the renal stone. So we will be talking about certain factor that increases precipitation, and certain factor that decreases precipitation. So factor increasing precipitation and factor decreasing precipitation. So whenever we are thinking about any factor that increases precipitation, it is mostly calcium. So if there is more amount of calcium being filtered, then there is a it is highly likely to be precipitated as a renal stone. Not just calcium, also oxalate, along with that uric acids, and not even that, also we can have drugs. So so this substance, whenever they are present in the urine in a higher amount, then these are very likely to be precipitated, and hence these are the precipitating factors. So let us now talk about the factors which decreases precipitation. And this factor usually inhibits the formation of this precipitate, and thus inhibits the formation of the renal stones. So what are the factor that decreases precipitation? The most important factor that decreases precipitation is citrate. So citrate is the most important factor that decreases precipitation. Along with that, there are other factors like nephrocalcin. So nephrocalcin, and also other factor like osteopontin. Hmm. But you should at least remember citrate as a major inhibitor of the precipitator factor, and it is a protection factor as well. So whenever in our body, if there is increased amount of when there in our in body, if there is increased amount of the precipitating factors like calcium, oxalic, uric acid, and drugs, and whenever there is a decreased amount of of substance that inhibit precipitation, like citrate, nephrocalcin, and osteopontin, then it is very likely the precipitate to be formed and hence manifesting with the renal stone. But there are other precipitating factors. These precipitating factors are aggravated by other factors. So there are other factors that should also be taken into consideration when we are discussing about nephrolithiasis. And along with these precipitation factors, so what are the other factors that will let us know whether the stone will be forming or not? So as I've already discussed, increased amount of solid with decreased amount of solvent, that will result into supersaturation, and supersaturation will result into precipitate. Along with that, the other factors are pH. So when we'll be studying different type of renal stone in this video, we can see that some of the renal stone are being formed in the acidic urine, whereas some of the renal stone are formed in the basic urine. So pH plays a very important factor. Along with that, we should consider about the hydration status. So hydration status. So I have already discussed about the hydration status, because whenever we drink less amount of solute, then the urine will be highly concentrated, and this concentrated urine has a very high chance to be precipitated in the form of stone. And also presence or absence of infection. So because infection will also have a major role in case of formation of a renal stone, that will be discussing subsequently. So there can be any sort of infection. Whenever we are talking about infection, we will be discussing infection produced by urease producing organism, and that will manifest with struvite stone or triple phosphate stone. Or whenever we are talking about infection, this infection mostly in the urinary tract, as also it is also known as upper urinary tract infection or acute urinary tract infection. Whenever that happens, then there will be damage of the cells there. Along with the bacteria will also be damaged, and this bacteria, the cell membrane of this bacteria will act as a nidus. So it will act as a nidus, and around this nidus there will be formation of the stone, or there will be aggregation of the crystals, and that will manifest with renal stones. So we can see the pathogenesis, that we will be discussing about several predisposing factors on the genetic basis of disease in the subsequent topics on the different stones in this video. And along with that, some lifestyle factors and the dietary factors with some metabolic defect that can be acquired, and these will all contribute to formation of an initiating nidus. And around the nidus there will be deposition of the stone, and around the nidus there will be deposition of the stone in the urinary tract, and that will manifest with nephrolithiasis. So now let us discuss about the different types of stone that we can manifest in case of nephrolithiasis. So as I've already said, there is a initiating nidus. So this initiating nidus is different in case of different type of renal stone, right? So there is a whenever we are discussing about the type of renal stone, it can be cystine stone, it can be calcium stone, it can be uric acid stone, or it can be struvite stone. And it's a matter of fact that calcium stones are the most common stone. Usually they are 80% of all the stone that we see in the renal tract, and calcium stone can be in the form of calcium oxalate or in the form of calcium phosphate. I'll be telling why we are discussing these two in a single pattern. And the next stone that is very common is our struvite stone. So struvite stone is the next common stone, and followed by uric acid stone, and the last one is cystine stone. And we can also see other stones which are not belonging to these type of stones. So let us start our discussion with calcium stone. So this is the same classification that we see in the Robbins, and as I've already said, the most common type of stone is our that is usually it is 80% is our calcium oxalate stone, also known or the calcium phosphate stone. I'll be telling why I'm discussing both of these together. So let me discuss about calcium oxalate stone. As I've already said, it is the most common stone in the kidney or in the urinary tract, and it's usually seen in adults. So it is usually seen in adults, like all the tumors. All the stones, and it is radio opaque in the nature. So it is radio opaque. So by using normal non-contrast radio imaging, we can identify this stone as well. And it is a matter of fact that it is pH independent. So I'll be telling why it is pH independent. So independent, whenever we are talking about calcium stones, it is very likely to be precipitated in case of alkaline medium. But whenever I am discussing about calcium oxalate stone, there are two facts to this. So what are the two facts is that the initiating form of this stone is known as Randall plaque. So Randall plaque, and this Randall plaque is actually calcium phosphate. So it is actually calcium phosphate, and around this calcium phosphate, so this calcium phosphate will act as a nidus. So it will act as a nidus, and around this calcium phosphate, let us consider this is our calcium phosphate. and around this calcium phosphate there is deposition of there will be deposition of the stone in that is known as calcium oxalate, right? So one of them is dependent on acidic medium, whereas another one is dependent on the basic medium. And because of these two factors, hence we call it as pH independent, because it can be seen in patient who usually have an alkaline urine, and it can also be seen in patient who have a acidic urine. So I'm talking that it is pH independent just because of this fact. And you should know the initiating or the starting point of this stone is known as Randall plaque, and this Randall plaque is actually a calcium phosphate, and around this calcium phosphate there will be deposition of the calcium oxalates, and this will result into formation of the renal stone. So let us talk about Randall plaque, and these are the Randall plaque, and we can see this plaque will be deposited at the tip of the renal papilla. So these are the renal papilla, and at the very tip of the renal papilla there will be Randall plaque, and around this Randall plaque there will be formation of stone, and that stone is our calcium oxalate stone. So Randall plaque are subepithelial calcification of the renal papilla. So it is usually less than 2 mm, and 2 mm is the greatest dimension of this stone. And around this Randall plaque there will be deposition of calcium oxalate stone. Hence it will act as anchor for the calcium oxalate stone. And around this calcium oxalate will precipitate as a crystals, hence forming the renal stone, and that will lead to the renal stone formation. And Randall plaque is seen as a crystal from through the process of nucleation when the urine becomes supersaturated with calcinogenic substances. And whenever there is formation of the Randall plaque around the tips of the renal papilla, so let us consider this a kidney, and these are the tips of the renal papilla, and in the tips of this renal papilla there will be formation of the Randall plaque, the calcification that occurs, and that is usually a calcium phosphate. And around the calcium phosphate there will be deposition of the calcium oxalate crystals, and that will manifest with formation of calcium oxalate stone. And what are the causes of formation of calcium oxalate stone? So let us discuss about that. So anything that will result into increased level of calcium or increased level of oxalate in the urine, that will lead to supersaturation of calcium and oxalate, and hence forming the calcium oxalate stone. So what can be the causes of calcium oxalate stone? It can be idiopathic hypercalciuria, it can be hypercalciuria, it can be hypercalcemia and hypercalciuria. It is a second intact entity. So let us discuss about it, because you might get confused by seeing this chart. So let us discuss about what are the causes of calcium oxalate stone. So the first cause, as I have already mentioned, it is known as idiopathic hypercalciuria. So idiopathic hypercalciuria. So you can understand idiopathic hypercalciuria. So the term itself says idiopathic and hypercalciuria, and it's in this patient when we see the blood or the serum level of calcium, they are absolutely normal, and this patient has normal level of calcium in the serum, but due to unknown reason, this patient usually excrete more or they filter more amount of calcium, or they excrete more amount of calcium, and that will manifest with increased calcium level in the urine. So due to this will manifest with increased calcium level in the urine, and in fact it is the most common cause of renal stone, or the most common cause of calcium oxalate stone is idiopathic hypercalciuria. So the next cause is our hyperparathyroidism. So hyperparathyroidism. So in this disease there will be increased level of parathyroid hormone. So this increased level of parathyroid hormone can be due to primary cause or secondary cause or even tertiary cause, that I will be discussing in case of endocrinology pathology videos. So hyperparathyroidism, it is associated with increased level of parathyroid hormone, and this parathyroid hormone will result into increased calcium level from the bones, from the intestine, from the kidneys, and eventually what happens is that this increased calcium level in the blood will be filtered out, and hence increased amount of calcium will appear in the urine, and this will manifest with renal stone. And the third cause is hyperoxaluria. So hyperoxaluria. So there are various concepts to be cleared regarding hyperoxaluria, because and there can be several diseases associated with hyperoxaluria. It can be primary, it can be secondary. So let us talk about primary hyperoxaluria. So there is a substance known as glycoxylate, and this is usually transaminated into glycine. So it is usually transaminated into glycine via an enzyme. So if there is a defect in the enzyme, that will manifest with increased amount of glycoxylate formation and decreased amount of glycine formation. Hence increased amount of glycoxylate will be filtered through the our filtration system in the kidney, and it will eventually appear in the urine, and hence increased amount of glycoxylate in the urine will be combining with calcium, and hence thus forming calcium oxalate stone. And that is our concept regarding primary hyperoxaluria. So let us talk about secondary hyperoxaluria that can be associated with several other disorders, and one of them is known as our intestinal disorder, and that is our inflammation of the intestine, and one of them is Crohn's disease, Crohn's, Crohn's disease. So let us discuss how Crohn's disease will manifest with calcium oxalate stone, because whenever you will see the Robbins, what it will say in case of the when you will study the inflammatory bowel disease, and when you study the Crohn's disease, it will be mentioned in the complication as renal stone in the form of calcium oxalate. So let us discuss how does this happen, and this is a very high yield point as well. So let us consider this is our terminal part of the intestine, and this is our liver. So in the terminal part of the intestine, usually bile salt is being transported or reabsorbed by enterohepatic circulation into the liver. So what I said is that this is our terminal part of the intestine, and from the terminal part of intestine, what happens is that the bile salt will be reabsorbed into the liver. So and because of this, what happens is that the calcium and the oxalate that is present in the intestine, they will bind with each other, and this bound form of calcium oxalate will be eventually appearing in the feces. So it will eventually be appearing into the feces, and hence it will be expelled, right? But let us consider a condition known as inflammatory bowel disease, where when in this condition, what happens is that, let me remove this for a moment. So in this condition of inflammatory bowel disease, so let me tell what happens in case of inflammatory bowel disease. So so let us again make about the terminal part of the intestine, and now the intestine has been inflamed. So because of that, what happens is that the bile salt will not be reabsorbed because of the defective transporter or the defective absorption system. Now the bile salt will not be reabsorbed from the terminal part of ileum, and this bile salt will now combine with calcium. So and hence the calcium and bile salt eventually will appear into the feces. And now because of this, the oxalate cannot bind to the calcium because calcium has now been bound to the bile salt, and this increased amount of oxalate, which is free form, it will be absorbed from the intestine, and it will reach to the blood, and from the blood it will be filtered by the kidney, and into the kidney it will be appearing into the urine. So there will be increased amount of oxalate in the urine in case of Crohn's disease, and hence Crohn's disease will also result into hyperoxaluria. So the third condition that I will associate with hyperoxaluria is known as ethylene glycol poisoning. So ethylene glycol poisoning. So as if you have seen my videos on alcohol pharmacology, I have said that whenever ethylene glycol is an antifreeze agent, and it is usually consumed or by the child, and it is usually metabolized to form oxalate, and as a result of which the amount of oxalate in the blood will increase, and if the amount of oxalate in the blood will increase, it will eventually be excreted, and hence result into oxaluria, right? So I have discussed several causes of calcium oxalate stone. I hope you are clear about the calcium oxalate stone, right? So now I have discussed about the pathogenesis regarding the calcium oxalate stone, and I have said that the causes can be idiopathic hypercalciuria. It is the most common cause. The second cause I have said about hyperparathyroidism. Then the third cause I discussed about hyperoxaluria. It can be primary or it can be secondary. So primary hyperoxaluria is due to enzyme defect, as I have said, and the secondary hyperoxaluria is due to Crohn's disease. It can be due to ethylene glycol poisoning and so on. Right? And it has a nidus. Calcium oxalate stone has a nidus, and this nidus is known as Randall plaque. So it is known as Randall plaque, and it is usually found in the tips of the papilla. So and that is all about calcium oxalate stone and its pathogenesis. Now let us discuss this calcium oxalate stone will be precipitated into the urinary tract from the kidney up to the urethra. And what happens is that this calcium and oxalate lead to formation of a crystal, and this crystal can be calcium oxalate monohydrate crystal, or it can be calcium oxalate dihydrate crystal. So we do not need to know a lot of detail about this crystal, but what we should know is that whenever we in the urine, if we see any crystal, and this crystal is, if it is a dumbbell shaped crystal, then it is known as calcium, then that crystal is of calcium oxalate monohydrate crystal. And if we see another crystal, and that is a bi-enveloped shaped, or bipyramidal shape or envelope. So this, as we can see, these are two pyramids, so bipyramidal shape or an envelope shaped crystal, then we should suspect there is formation of calcium oxalate dihydrate crystal, and this is usually asked in MCQ, the shape of crystal as well, right? So how can we treat calcium oxalate stone? We can treat calcium oxalate stone by decreasing the amount of calcium that is being filtered through the urine, or decreasing the amount of, sorry, not filtered, that is appearing into the urine, right? So we can decrease the amount of calcium that is appearing into the urine by giving certain medications like thiazides. So thiazide, it will act by the sodium chloride co-transporter, and it eventually it will lead to increased absorption of calcium, and because of increased absorption of calcium, less amount of calcium is being less amount of calcium will appear in the urine, and hence decreasing the chance of formation of calcium oxalate stone, right? So we have discussed all the aspects regarding calcium oxalate stone, and let us go over to the next stone, and that stone is our struvite stone, right? So the next stone that we'll be discussing is about struvite stone, and I have said it as it is the second most common type of the renal stone, and the precipitating cause or the most common cause here lies in the fact that it is usually caused due to a renal infection. So struvite stone, so it is also known as triple stone, because it is made up of three components. It is known as magnesium, ammonium, and phosphate stone. So as I have already said, struvite stone, it is also known as triple phosphate stone, also known as MAP stone, also known as triple stone. So it is the second most common type of stone. So it is the second most common type of stone, and it is a very slow growing tumor. Slow growing stone. Right? It's a very slow growing stone, and it will eventually grow up into and fill up the entire pelvis, and that will manifest with a stag horn. So it is also known as stag horn stone. So staghorn is basically morphology that we associate with struvite stone, and it is very commonly seen with struvite stone. It is not that you will only see staghorn stone in case of struvite stone, but you can also manifest staghorn stone in case of cystine, in case of cystine stone as well. But the most common cause of staghorn stone is the struvite stone, and it is a point to be noted as well. So as I've already said, the precipitating factors or the most common cause being discussed here is the renal infection. And whenever we are talking about the renal infection, it is the infection that is caused by urease producing organism or urea splitting organism. So urease positive infection. So what are the organisms that are urease positive? These are proteus organisms. So proteus species, one of the organism that is Proteus vulgaris. The second, we can be discussing about Klebsiella. We can also discuss about Pseudomonas, and there can be also discussion about Staphylococcus saprophyticus. So Staphylococcus saprophyticus, and these organism have a urease enzyme. So this urease enzyme will break down urea, and formation of ammonia occurs, and this ammonia will make the medium alkaline. So it will make the medium alkaline, and in this alkaline medium there is a very high chance of precipitation of this component like this magnesium, ammonium, and phosphate. And because of this precipitation of magnesium, ammonium, phosphate, and it will manifest with a very slow growing stone, and that will fill up the entire renal pelvis, and in the form of a morphology of staghorn appearance. Hence it is known as staghorn stone. It is also known as struvite stone. It is also known as triple phosphate stone, right? And the so we have all, and this stone, the point of interest is is that it is also a radio opaque stone. It is radio opaque, and as I have discussed earlier with calcium oxalate, it was also radio opaque. And this is usually a pH dependent, and the pH that it is from is alkaline pH. So it is usually formed in the alkaline pH, right? And the pH is alkaline in case of urinary tract infection with urease positive organism, and hence in patient with urease positive organism, these stones are very common, quite common as compared to the normal individuals, right? So uh, m- so what happens is that so how these crystals of this stone will appear in the urine. So as I have discussed with calcium oxalate stone, the monohydrate and the dihydrate forms, so even the struvite stone, the crystals, as they are precipitating, they can also appear in the urine. So this the type of the appearance is known as coffin lid appearance. So it is known as coffin lid appearance. So coffin lid appearance, and you can see the stone like this. So the stone is like this, and this stone is known as coffin lid appearance. As discussed with the calcium oxalate stone, see, do not get confused with calcium oxalate dihydrate stone. This is known as enveloped stone, or also known as bipyramidal stone. But the stone that we associate with struvite stone is the crystal that we associate with struvite stone is having an appearance of a coffin lid, and hence it is known as coffin lid appearance, right? So now we have already discussed the important parameters regarding the struvite stone. As we can see, this is a stone which is filling the entire pelvis like a stag horn, and hence it is also known as dragon appearance of stone, right? And this bacteria signifies that it is a it is a urease producing organism, and this organism I have discussed, it is Proteus vulgaris. It can be Klebsiella, it can be Pseudomonas, and it can be Staphylococcus saprophyticus, right? So this is about the staghorn. So we have already discussed about the calcium oxalate stone. We also discussed about struvite stone. So now we have the 2.2 to be discussed, and that is our uric acid stone, and that is our cystine stone, right? And the third most common stone is our uric acid stone, and it is usually associated with hyperuricemia. And this hyperuricemia can be associated with increased level of uric acid in the blood, or may not be. So let us discuss about uric acid. So uric acid stone is associated with urine pH, that is acidic pH. So patients who have acidic pH, they have a predisposition to develop a uric acid stone as compared to the normal individual, right? And so let us talk about uric acid stone. So it is the third most common stone. It is the third most common stone, and it is a very important point to be know that uric acid stone as radiolucent. So it is radiolucent. So it cannot be diagnosed with your normal X-ray KUB non-contrast imaging. So it is a radiolucent stone to be noted, and it is usually associated, as I've already said, it is associated with hyperuricemia. So the patient will expel excrete a large amount of uric acid in the urine, and it is usually associated with hyperuricemia. And this hyperuricemia, what are the causes that could lead to hyperuricemia is gout. So gout, so it is a metabolic disorder. It can be primary or secondary gout as well. The next condition is known as tumor lysis syndrome. The next one, as we discussed, it is tumor lysis syndrome, or it can also be associated with Lesch-Nyhan syndrome. So with in all these conditions, there will be increased breakdown of purines, right? And this increased breakdown of purine will result into formation of a large amount of uric acid. So as we know, the purine will be broken down into the uric acid, and this high amount of uric acid in the blood, eventually they will be filtered, and hence there will be hyperuricemia. And this hyperuricemia, especially in acidic pH, will be precipitated as a uric acid stone, and it is the third most common stone, and it is radiolucent in appearance, right? So approximately 25% of the patient with uric acid stone have a gout, right? But as I've already said, it is not just gout. It can be associated with tumor lysis syndrome and also with Lesch-Nyhan syndrome as well. So the other risk of getting uric acid stone is patient who live in hot and arid climate. Not just that, low urine volume. This will also be a precipitating factor for formation of the uric acid stone. And whenever I will be discussing about the appearance of the uric acid stone, it is usually irregular in size. So it does not have a significant shape and size of its own. So the appearance is irregular in size. And how do we treat this disease is by decreasing the amount of uric acid forming in the body and eventually getting excreted, and that can be done by allopurinol therapy. So allopurinol will stimulate the xanthine oxidase, it will inhibit the xanthine oxidase enzyme, and hence decreasing the production of uric acid. Along with that, as we say, it happens in the acidic urine, we can also alkalinize the urine. So it can be the urine can be alkalinized, and it can be alkalinized by using potassium bicarbonate, and hence it will be the urine will be alkaline and decreases the chance of precipitation, right? So and let us now discuss about the third stone, and sorry, our fourth stone, and that is known as cystine stone. So cystine stone. Okay. So what are the important facts regarding cystine stone? So it is, as I've already said, it is the fourth common type of stone that will be manifested into the renal tract, and it is usually associated with cold disorder. So what does cold disorder means, right? So it is usually associated with a defect in the dibasic amino acid transporter. So whenever there is defect in a dibasic amino acid transporter, and because of this defect in dibasic amino acid transporter, a large amount of amino acid will not be getting reabsorbed from the kidney, and eventually this will be appearing into the urine, right? So what are the different type of dibasic amino acid? It can be remembered by the name col itself. So C stands for cystine, O stands for ornithine, A stands for arginine, and L stands for lysine, right? So if there is defect in this transporter, this amino acid will not be absorbed from the kidney, and hence there will be increased excretion of this amino acid. And the most common amino acid that is being excreted, and that is a dibasic amino acid, is our cystine. And whenever there is increased amount of cystine in the urine plus acidic urine, this will manifest with cystine stone, right? So cystine stone, what I said is that it is due to a defect in dibasic amino acid transporter that will manifest with increased amount of cystine in the urine, and that will manifest with cystine stone, and the precipitating factor being the acidic urine. Hence acidic urine will precipitate the formation of this stone, right? And so So how is the crystal that is appearing in the urine? The crystal that we see in this type of stone is hexagonal shape. So it is usually a hexagonal shaped stone, right? So this type of stone can be appreciated in the urine. Crystal can be appreciated in the urine. Hence, we can be sure that it is a cystine stone. And how do we treat this? So we can treat this by maintaining the hydration status, by staying hydrated all the time, plus alkalinizing the urine, because this stone is also formed in case of acidic urine. So as I've discussed with cystine stone, it is occurring in case of cystinuria, and it is autosomal recessive disease that is characterized by increased amount of or increased concentration of amino acid cystine in the urine, as I've already discussed with cold disorders. Not just cystine, it can also be ornithine, arginine, and lysine as well, but the most common being the cystine. And hence there is formation of the cystine stone in the kidney. It can occur in the ureter, and it can occur in the bladder, right? So it is usually precipitated when the urine is acidic, right? So let us now talk about the morphology. I have already talked about the morphology of the crystals that we see in the urine in case of different the different stones. So in basic, as a whole, how do we discuss about the morphology? So whenever we are talking about the renal stone, these renal stone are in 80% of the cases are unilateral, and the rest of them it is bilateral. And the favored site of deposition, as I've already said, it is most commonly seen in case of the renal, in within the kidney itself, and then it can be seen in ureter, bladder, and urethra, right? So in kidney, it is most commonly formed within the renal calyces and the renal pelvis, and then the next common site is the bladder, right? So in the kidney, there are renal papilla, and there is a space, and in this space is known as renal sinus, right? And in this space, we can appreciate these are the minor calyces along with major calyces, right? With And in this space we can appreciate the renal stone more commonly. So if formed in the renal pelvis, they tend to remain small, having average diameter of 2 to 3 in diameter. But rarely what happens is that this stone can get very large in appearance, and progressively it can fill up the entire, it can fill up the entire the renal pelvis. So as I said, it will appear very large, and it will fill the entire renal pelvis, leading to formation of stag on calculi that I have already shown you the diagram of. Diagram, I have already shown you. So I have also said that it is usually found in the unilateral kidney, and the stone can have a smooth contour, or it may also occur in the form of irregular and jagged appearance. So it can be having smooth contour, or it can be having irregular or jagged mass of spicules. And because of this irregular mass, whenever it is passing through the ureter, it can lead to damage of the passes, or it can lead to damage of the mucosa, and hence it will manifest with painful hematuria. It will manifest with painful hematuria, right? So we have discussed about the morphology. As I've already said, in calcium oxalate we can appreciate this type of crystal. This is a dye this is our dihydrate form of crystal, and as I've already discussed, it is a bi-envelope shaped crystal. In uric acid crystal, we can appreciate multiple morphology, so it does not have an intact morphology of its own. In case of struvite crystal, as I've said, it is a coffin lid appearance, so we can see this is a coffin lid appearance. And in cystine, we can appreciate the hexagonal shaped crystals, right? So I've already discussed this fact as well. And stagon calculi, it is let me change the color of this diagram. So as we can see, the stagon will fill up the entire renal pelvis. We can see it is filling up the entire renal pelvis, and these are stagon stone. So let us discuss about the clinical features regarding the renal stone. And the most common clinical feature is let me change the color. The most common clinical feature is our abdominal pain. So abdominal pain is the most common clinical feature, and it is the most common symptom that the patient will present into your OPD, right? Not just OPD, it will present in the emergency department, because the renal stone, the pain of the renal stone are one of the very severest form that one can have in their life. So it is the clinical feature, as I've said, is the most common is our abdominal pain, and that is usually in the flank region. So in this flank region, the abdominal pain happens. And whenever let us consider this is a kidney, and whenever the kidney, the stone is passing through the ureter, during the passage through the ureter, what happens is that it will stress the wall of the ureter. So during the passage, it will stress the wall of the ureter, and due to stress, it will result into a very intense peristaltic movement, and that will lead to contraction of this ureter, and that will manifest with renal colic. So if any stone or mass in the ureter, that will stress the ureter, that will result into hyperperistalsis, and that will manifest with renal colic. Although it is known as renal colic, but the appropriate name would be ureteric colic, because it is happening when the stone is basically present in the ureter and it is stretching the wall, and that is result into hyperperistalsis, and that is manifesting with pain, that is that is manifesting with a colicky pain. And this colicky pain is not stagnant, and this pain is radiates from the loin to the groin area. Yeah. So whenever the stone is present in the, so let us talk about whenever the stone, so let us consider this is a ureter, and this is the upper one third of the ureter, this is the middle one third, and this is the lower one third of the ureter. Whenever the stone is present in the upper one third of the ureter, and because of this stone, it will in male, it will, whenever this stone is present in the upper one third of the ureter, the pain in male, it will radiate towards the testicular tissue, and in female it will be radiating towards the labia majora. So whenever the renal stone, it is present in the upper one third of the ureter, it will, in male it will manifest with the pain near the testicular tissue, and in female it will manifest with the pain near the labia majora. So in patient who are having the renal stone in middle one third of the ureter, the pain will be radiating towards the iliac fossa. If it is present in the right side of the ureter, it will result into pain in the right iliac fossa, whereas if it is present in the left ureter, in the middle one third, then it result into pain in the left iliac fossa. Why I am mentioning this is because whenever there is a pain in the right iliac fossa, then we usually think it is an appendicitis pain, but it can also happen that it can be also associated with pain in the renal due to renal stone. And whenever we are talking about the pain in the left iliac fossa, we usually think about Meckel's diverticulitis, but mind you, it can also happen in case of renal stone as well. So these are the differential diagnoses that you can think whenever the pain is occurring towards the iliac fossa region. So but whenever there is a stone that is impacted in the lower part of the kidney, or sorry, in the lower part of the ureter, the lower one third to be, in fact, the pain will be radiating towards the groin region. So this is all about the clinical features about the renal stones. So now, as I've said, renal stone can be asymptomatic, but whenever it is, but usually it is associated with symptoms. And whenever it has a symptom, the most common symptom is the abdominal pain, and this pain causes very significant and intense pain, and that is the colic pain that is radiating from the loin to the groin. And whenever there is a larger stone, that will manifest with hematuria. Not just larger stone, even the smaller stone, if they have a jagged appearance, and then they will erode the wall of the mucosa, and that will manifest with hematuria, and this hematuria is a painful hematuria, right? So what are the complications that a person can have if they have a renal stone? So whenever there is a renal stone, so let us consider if there is a renal stone here, then as we know, the kidney will filter the urine, and eventually the urine will appear into the ureter, and eventually it will go through the urinary tract. But if there is a stone in the in this, that can result into large amount of water or the urine in the ureter itself, and that will manifest with hydroureterosis if it is very significant, if that is a very significant condition. But whenever there is a hydroureterosis, it is usually first condition is known as hydronephrosis. Whenever there is a formation of the there is when the kidney will be a bag of urine, then it is known as hydronephrosis, and this hydronephrosis with time it can result into hydroureterosis as well. And even when there is obstruction to the urinary flow, the urine become stasis, so there will be stasis of the urine, and in this stasis, whenever the urine is stagnant and the stasis urine, there is increased risk of infection, and this will manifest with pyelonephritis, and eventually the kidney may be converted into a bag of pus, and this condition is known as pyonephrosis. And whenever there is a kidney in the urinary tract, it will manifest with increase hydrostatic pressure within the tubules or within the Bowman space, and that will manifest with a decrease in the glomerular filtration rate, and that will manifest with a post renal failure. So these are all the complications regarding the renal stone. So now let us talk about how do we diagnose renal stone, and what are the treatment measures that we can do. So this is not a part of a medicine. I am talking about a pathology lecture, so I will just give a small hint regarding the diagnosis and the treatment. So I have already discussed about the treatment of each renal stone in their individual section as well. So whenever we think about treating the renal stone, we should initially manage the pain. As I've already said, the most common symptom and the most severest form of symptom is the renal, the pain itself. So the pain can be managed by using an NSAIDs.
So pain can be managed, but if it is very severe enough, then we can use other painkillers as well. So regarding the definitive treatment, however, remains the surgery. So the definitive treatment is surgery. If the renal stone is less than 2 centimeter, then the surgery that we prefer is that is exogenous shock wave lithotripsy. Exogenous shock wave lithotripsy is done whenever the renal stone is less than 2 centimeter. But whenever if the renal stone is more than 2 centimeter, we do not perform exogenous shock wave lithotripsy. The if the renal stone is more than 2 centimeter, what we perform is PCNL. PCNL is known as percutaneous nephrolithotomy. If the renal stone is more than 2 centimeter, what we perform is PCNL. It is also to be known, and it can be asked as a question as well. So we insert we will approach the kidney from the backside, because kidney being a retroperitoneal organ, and we will approach the Morrison parallelogram. So by doing a surface landmark, then we will go through the instrument and we will break the stone via the posterior approach, and eventually we will clear out the stone from the renal tract as well. So these are our treatment measures. So let us talk about the diagnosis. And the diagnosis is usually done by scanning. So radiological scanning, and the preferred scanning is helical non-contrast CT scan. So helical non-contrast CT scan is done, is the preferred, and is the most it gives the most accurate results. But if the patient do not have enough money, then X-ray KUB can also be done. X-ray KUB, but it is to be noted that whenever we are performing KUB or X-ray KUB, that is a plain X-ray, then only the 90% of the stones are being picked and the 10% stone are being left out. So it is not a good diagnostic test, because as I've already said, uric acid stone, they are radiolucent, and similarly other stone can also be radiolucent. So by this, only 90% of the stone can be picked up by radio imaging if we do X-ray KUB. Ultrasound can also be done. So whenever we are talking about X-ray KUB, or the another fact to be known is that uh, while performing X-ray QV, we should first give the patient purgative or laxative, because there can be fecolates if we do not give this, and this fecolate with may interfere with interpreting the X-ray as well. So in this video, I have discussed a lot about the renal stone. Every aspect of the renal stone regarding the pathology has been covered in this video. Most of the aspect has been covered, and also I have discussed about the clinical features, the complications, the treatment strategies, and the diagnosis of choice. And I would like to conclude this video by thanking you all for your patient listening. Thank you very much.